EMGs can be poorly tolerated due to the pain and patient intolerance, which can lead to suboptimal or limited studies. This study aimed to see if 400 milligrams of ibuprofen taken 2 hours prior to EMG versus a placebo would decrease the amount of muscle pain experienced by patients. 30 healthy volunteers completed this study. For the whole cohort of volunteers, immediate recall of EMG pain was significantly decreased by ibuprofen. The VAS immediate pain score was 33 plus or minus 17 with placebo versus 25 plus or minus 16 with ibuprofen, and this was statistically significant. The result of this study demonstrates that the use of ibuprofen prior to EMG reduces the immediate perception of muscle insertion pain, but it did not yield significant results for the memory of pain nor the perceived residual pain a day later. Pre-medication with 400 milligrams of ibuprofen taken 2 hours prior to test is useful. However, caution should be taken in patients with renal insufficiency or patients with a history of gastrointestinal bleeding. Here is another approach to help decrease pain from needle EMG testing. 99 adults underwent needle EMG and were randomized into either 2 experimental or control groups. This was a prospective, blinded, randomized controlled study that looked at subject satisfaction with the level of pain from needle EMG with using either EMLA cream or vapocoolant spray compared to no analgesia in the control group. The EMG needle insertion site was the medial head of the gastrocnemius. In the experimental groups, vapocoolant spray or EMLA cream were applied before needle EMG. In the control group, needle EMG was performed without pretreatment. In the vapocoolant spray group, the insertion site was sprayed from a distance of 30 centimeters for 5 seconds, or until the skin was blanched, just prior to the EMG practitioner entering the room. The study found that pain intensity was significantly lowered in the group given the vapocoolant spray prior to EMG. There was no statistically significant difference in pain between the EMLA and control groups. Patient satisfaction with the study was also higher in the vapocoolant group compared to the EMLA and control group. Thus, it may be helpful for practitioners to have vapocoolant spray for patients with low pain tolerance. While high-quality studies are important, there are many clinical pearls that can also be used to make EDX studies less painful. The Digital Media Education Committee has come up with a few ideas that may be worth trying in your practice. To help with patient comfort, it may be useful to avoid specific words that have negative connotations. Most patients think of large bore IV with multiple failed attempts to get blood when they hear needle, so you may want to describe it as a recording electrode, an antenna, or a fine wire. Similarly, replace shocks with stimulations to describe the sensation with more neutral terms. And don't forget to smile and be at ease when describing the test to patients. Non-verbal communication can convey negative vibes. The abductor pollicis brevis, or APB, is an oft-studied muscle during the work of median mononeuropathies. Textbooks show needle placement in the mid-volar thenar eminence. However, this location is rich with sensory endings and can be very painful. Instead, consider this tip. Insert the electrode on the border of the first metacarpal rather than the mid-thenar eminence. Use a steeper angle, but only insert to a depth of a few millimeters. Use traction of the skin with your other hand to make the insertion smoother. To activate the muscle, gently push the thumb upward to the midline rather than resisting against the patient's thumb to reduce tension and pain. Stay as superficial as possible during voluntary action. From all of us on the AANEM Digital Media Education Committee, we hope that this information will be useful in your practice.